Good morning, everybody, and welcome to this edition of MacroPro and Friends. I'm Diane Cohen, Vice President of Client Services and Education for MacroPro. We are so delighted to have you with us today. And speaking of delighted to have people with us, I am really excited to have Dr. Altman with us. Dr. Altman, how are you?
I'm great. Looking forward to speaking today.
Yeah, so can you tell us a little bit about what your company does and what your role is? I know you're going to do a little bit more of that, but maybe you could just give us a sneak peek.
Yeah, so our company is a brain injury specialty program that provides residential care, outpatient care, supported living, and home and community care. My role is as the Director of National Outcomes. So I'm involved in collecting our outcomes, publishing, looking at quality assurance. My background is as a neuropsychologist, got my PhD up in the Northwest. Up in Victoria, British Columbia, and then later went and got my MBA. So I have been both involved as a clinician and as an administrator. Ran inpatient rehab units all the way to outpatient programs.
Very nice. Well, it's nice that you were in the Pacific Northwest, is where I hail. Where are you currently living?
I'm living in Arizona. I'm in Paradise Valley, Arizona, which is in the Phoenix area.
Oh, very nice. Well, for those of you watching right now, if you would put in the question box or the chat box where you are watching from, that would be really great for us. We'd love to see where you're coming from. And while you're putting that information in, I'm going to do a little bit of housekeeping. So today's webinar is worth 1 CEU credit. You need to be logged on to the GoToWebinar platform, so you need to be able to see us from your computer screen or your phone, wherever you're at. Phoning in alone will not get you a certificate, so you need to make sure you're logged on so that they can take your time in attendance. You'll get your certificate within 1 hour after this presentation. If you have any questions at all for this, for the doctor, please put into the question box, and if there's time, we will ask those questions of doctor. If not, we will provide them to him, and then he can return it back, the questions back to you. And he does have handouts, so it is in the control console under handouts, so be sure to download those. And then lastly, you'll be able to watch this on the MacroPro YouTube channel. And I think that's everything for right now, except I do want to reiterate that you need to be logged on. And if you have some issue with your certificate, it's usually a firewall. Ask your IT department about it. But if not, I can assist you for 30 days. So make sure to get a hold of me within the first 30 days after the webinar if you haven't gotten it yet. And now I'm going to turn it over to you, Doctor. And I can't, oh, wait a minute. I'm going to read real quick a few things. I see Manteca, Rockland, California, Sacramento, Henderson, Nevada, Lakeside, California, Sierra Foothills, Granite Bay, Sacramento. So there are people from all over that's joining us today. So thank you guys for typing that in. And Doctor, the floor is yours.
Great, thank you. So we're going to do the top 10 things workers' comp case managers and adjusters need to know about TBI. It sounds a little bit like a David Letterman top 10. Unfortunately, it's probably not going to be quite as entertaining as Dave. Number 1, the definition of traumatic brain injury was updated in 2010, making it easier to diagnose mild traumatic brain injury. The definition is an alteration in brain function or other evidence of brain pathology caused by an external force, which we'll talk about in just a moment, and at least one of the following signs: loss or decreased consciousness, and or loss of memory immediately before or after the injury, and or neurological deficits such as weakness, loss of balance, and so on. So when we're talking about external forces, we're really trying to contrast it to internal things that might happen, such as strokes or other kinds of disease processes. And there are basically 4 different external forces that we're going to talk about. The first is head striking an object. So it could be a situation where you are in a vehicle and you hit your head against the glass in the windshield or the glass on the door, but you're basically having your head strike something. Right? And that could also include falls. If you end up falling and you smash your head against something, that is a kind of injury that they're talking about. Acceleration, deceleration. The example I like to give families involving this is, if you had a plate and sitting on the plate was some Jello, and you jiggle that plate, the Jello jiggles as well. The problem is that it's sitting within a bony structure with lots of ridges in it, known as the skull. And when it jiggles, it's hitting against those ridges and causing damage. It is also, by its sheer physics, moving, accelerating, and decelerating, causing shear injuries. So fibers that are connected can also be torn. The third is foreign body penetrating the brain. Often people think about this as gunshot wounds, but there are many other kinds of injuries that involve penetration of the brain. And one of the most famous ones was in 1848. This individual, Phineas Gage, was working on the railroad, and he was using what was called a tapping iron to tap in the explosives when it suddenly went off in a surprising fashion and went up through his orbital bone, through his frontal lobe, and he became one of the most famous patients in neuropsychology because they could assess his functioning as a result of this very focal kind of injury and any kind of disconnections that might occur. The fourth is force from blast or explosion. And here we're not really talking about shrapnel. So when you think about the military theater where people have explosions that occur, it's not just whether there is debris that has come off of whatever has exploded. It's really referring to those air pressure waves, which are pretty severe enough to actually cause damage to internal organs in our body or even our brain. Number two, what are the three primary ways to assess brain injury? There's neuroimaging, neuropsychological evaluation, and functional assessment. Neuroimaging, computed tomography or CT scans. I'm sure you're all very familiar with that. They came about in the early 70s, I think 1973. In the 80s, we then moved on to magnetic resonance imaging, MRIs, that are preferred in subacute or chronic situations because patients usually have to lay still for considerable amounts of time to get a really good image. And it's a good follow-up to CT, but typically when a patient comes into the ER, they're going to do a CT scan as opposed to an MRI. We've evolved into other kinds of imaging, of course, diffusion tensor imaging that now can look at pathway damage. So even though the one end of that pathway might be fine and the other end might be fine, but in between there's this disconnection, and we're able to look at how that damage relates to function and outcome. Neuropsychological evaluations really provide us a roadmap for treatment. It is a baseline testing that is done at a specific time. So it's a snapshot in time that's looking at all these functions: cognition, emotion, behavioral functioning, perhaps academic, work reentry. And we're able to use that initial evaluation as a baseline to see the path that we are looking to improve that patient along. The issue with neuropsychological evaluations is you can't redo them repeatedly in a short period of time. So there has to be a determination when would be the best time to do that kind of assessment, or one must use a battery of tests that are specifically designed to be repeated to reduce practice effects and so on. The third area is functional assessment, and you may be familiar with some of these. The Glasgow Outcome Scale, that's not the Glasgow Coma Scale, made by the same group, but they're really looking at measures that from the patient from coma to community. The functional independence measure was a very popular one used across the country, more recently replaced by the CARE tool, the Continuity Assessment Record and Evaluation tool. And the third is the Mayo Portland Adaptability Inventory, the MPAI. This is a tool that many post-acute programs use. We're one of those programs that use it, in addition to an organization called Foundations to Advance Brain Rehab, FABR. This is a group of programs that are pooling their data so that they can do research together to look at outcomes. It also provides 3 indices: abilities, adjustment, and participation in the community. Participation in the community is more sort of a global kind of area, looking at things like, can the patient drive, their transportation needs? Are they able to manage their medication? How about money management? Those kinds of things. 3 other tools that are a little bit less often used nowadays are the disability rating scale, the communication integration questionnaire, and the short form 36 health survey. Brain injury claims are among the most costly claims a workers' compensation carrier will see, and they are rising. I probably don't need to be saying that. I'm really lecturing to the choir here because you're living this, but we do have some numbers we can look at. There was a consultant in California by the name of William Zachary who was quoted as saying, if we can identify and intervene very early, it is possible to really change the dynamic, change the outcomes. And that's certainly an important role that you all serve in, to help get these patients the right care at the right time as early as possible. Overall, head and brain injuries account for about 30% of mega claims, and mega claims here being defined as in excess of $10 million. Though such claims comprise less than 5% of all workers' compensation claims in most states, that's a huge number. When we look at the frequency of these claims, you can see this data from 2017 was on the rise. For patients that are spinal cord injury or brain injury or severe burns, you can see that the number of these claims was really rapidly going up. Number 4, why mild TBI can be so perplexing. Well, we get probably a huge number of questions on this topic. The most often the questions are things like, why is this patient not progressing more? Why are they not progressing more quickly? How come if they have such a minor injury, do they have so many problems? So let's see if we can look into this a little bit. The American Congress of Rehab Medicine in 1993 came up with this definition of mild TBI that sort of goes along with the definition we had earlier. Here they talk about the patient having at least one of the following: any period of loss of consciousness and or any loss of memory for events immediately before or after the accident, and or any alteration in mental state at the time of accident, for example, feeling dazed, disoriented, or confused, and or focal neurological deficits that don't exceed any of the following. They don't have a loss of consciousness that is longer than 30 minutes, or their Glasgow Coma Scale, which we'll talk about more in a few moments, is between a 13 and 15. 15 is the best score you can have. Or they do not have a post-traumatic amnesia that exceeds 24 hours. Post-traumatic amnesia is the time where a patient is unable to lay down new memories, they're disoriented, so that has to stop within 24 hours. So one of the things you may note here is that since these are all situations where at least one of these have to occur, that means you do not have to have a loss of consciousness in this definition to be considered a mild traumatic brain injury. So let's talk a little bit about these different levels of brain injury at time of injury: mild, moderate, and severe. Mild is often also called concussion. And you can see we're going to talk about a variety of things across the rows. Structural imaging. Here in mild, you will typically not have a positive finding. And one of the things I try to point out when we talk about mild TBI and radiological findings is we are limited by the technology. So many years ago, we used to rely on something called pneumoencephalography. Now, I don't know how many of you even know that term, but it was sort of like having a large light bulb behind the patient and some radiological film in front, and they would take this picture, and then whatever they saw on this picture, that is what they thought was going on in the brain. Of course, CT scans came along, that helped to see more things. MRIs came along, we see more. Now there's PET and there's a variety of other things. But back in when we were doing pneumoencephalography, that was a pretty crude measure. And when we look back on it from 2024 to back then, we're like, oh my God, they were like, cavemen, cave people. That's the kind of radiological findings they were using. Well, I wonder in 50 years from now, I'm not likely to be here at that time, if they'll look back at what kind of radiological examination we were doing in 2024, and someone might be sitting there, sort of saying in an arrogant fashion, oh, that's as if they were using a large light bulb with these PET scans to look at a patient's brain. So I will caution all of us that when we see a negative result in radiological findings in a mild traumatic brain injury, it may not be that there isn't damage. We just don't yet have the technology to be able to describe it and illustrate it. Going on to the definition, we've already talked about in mild TBI that the loss of consciousness is 30 minutes or less. Post-traumatic amnesia is 1 day or less than or equal to 1 day. And the Glasgow coma is 13 to 15. The lowest score one can have on the Glasgow coma is a 3. If you look at the severe column on the far right, here you can see the patients are between a 3 and an 8 and have what's called a severe brain injury. Again, all the metrics used are quite different than what were under the mild concussion column. When we look at TBI national stats, we see that 80% of all brain injuries are mild. Again, the term concussion is often used with mild TBI patients, and they occur about twice as frequently in males. And I don't think that's much a surprise, right? Males are out there doing riskier things, maybe taking on some courage in a bottle to help them do these things. But most often, twice as often, males are the ones that are having these injuries. And there seems to be 2 age clusters. There is a 15 to 24 and an over 70 and over range. And even though there are these 2 clusters, the causes are similar to those brain injuries. So for example, they both will have falls. So maybe the 15 to 24 age, again, have jumped off something. They're doing something risky. They're working in an environment that has more risk. While the 70-year-olds may not necessarily be working on roofs anymore, but they're having problems with vertigo or their mobility and may fall and suffer an injury. Motor vehicle accidents, right? The 15 to 24 age group may be more impulsive, while the 70-year-olds are less capable from a motoric standpoint or in a visual processing or attention and concentration standpoint, so they may have more accidents. Both groups are either struck or get struck by something. And then there's assaults, right? The 15 to 24 group might be more likely to get into a fight, while the 70-year-olds who might be more vulnerable may be assaulted by individuals in the community. So there's over 1 million people that experience a mild TBI each year in the US. The good news is most cognitive sequelae improve within 3 months. A small portion, right? Those are the ones that we see that have persistent symptoms 12 months or longer and are more likely to come to your attention and to our attention as providers. If they are people that return within 30 days to work, again, you probably may not see the case or may have very little to do with the case, and we will never see that kind of case. Mild TBI is also associated with the onset of psychiatric disorders, including depression and post-traumatic stress disorder. The DSM-4 had a criteria called post-concussional disorder, and the criteria was patient had to have a history of TBI causing significant cerebral concussion, needed to show cognitive deficits in attention and or memory. That could have been, complaints where people are saying they can't watch TV anymore, they can't stay on task to watch it and remember what's going on from scene to scene, or maybe they can't read a book because Their ability to stay attentive to a paragraph is really faulty. Or maybe it's a younger person who's playing video games and can't stay in attention and concentration on that task. There are also symptoms of sufficient severity that affect their social role functioning, right? That could be um, someone who's at home taking care of the kids and doing laundry and having trouble doing that multitasking. Or maybe it's a retired individual who can't manage their social calendar anymore. In any case, they would have to have at least 3 of the following 8 symptoms that appear after injury, and they have to persist for at least 8 months. And you can see all the different things that you might have already heard as complaints from individuals when you see these individuals that say, you know, I'm having trouble with fatigue, I have headaches, I'm irritable, or the family is telling you how irritable they are, or you as the workers' comp case manager or adjuster having to deal with their irritability. There can be personality changes. So we're going to talk a little bit more about that as well. The course of recovery, about 80% are uncomplicated and they resolve in 1 to 3 months following your injury. Maybe they had some initial speed of information processing or attention or memory, but they really get better pretty much on their own in about 1 to 3 months. However, 20% are considered complicated. Now, I want to talk about this term complicated because on the one hand, it's used here as a way to talk about that symptoms persist for longer than 3 months. The other way that it is used involves a situation where a patient has a mild TBI, they go to the ER, they do all the workups that they need to do, seem to be fine, they release the patient home with a symptom checklist for them to follow. A few days they come back, they've got a bleed in the brain, for example, now they need neurosurgical intervention. So they're called a mild TBI that is complicated. The worst example of this you may be familiar with is the actor Liam Neeson in 2009 was skiing with his wife, Natasha Richardson, in Mont Tremblant, Quebec. She suffered a fall, hit her head, and kept saying she's fine, she doesn't need treatment, she doesn't want to go anywhere. She suffered a pretty significant bleed, and by the time they got her to neurosurgical care, it was too late. So that would be considered a complicated mild TBI. There are factors associated with delayed recovery or poor outcome for mild TBI. They include increased age at injury. We know patients that are older are slower to recover and typically have more residual deficits. If a patient has premorbid psychiatric illness, if that patient already had depression or anxiety, those kinds of things will definitely slow the recovery and may result in a poorer outcome. If the injury itself helps the patient to develop psychiatric illnesses after injury, like post-traumatic stress disorder or depression, that will also affect the recovery curve and ultimate recovery. Compensation litigation. Well, we could spend a whole day talking about this, right? I mean, everyone knows when attorneys get involved, things start to change for that patient, not necessarily in the direction we would hope. And they sort of go off the rails at time because they don't seem to be following the typical kind of pattern. Repetitive injuries, right? We've heard a lot about this, involving sports, right? It used to be someone would get knocked out or partially dazed in a game. They would get slapped on their butt and get back in there. They would have their bell rung, it used to be referred to. Now we know that repetitive injuries can lead to pretty significant deficits or something that's called CTE, chronic traumatic encephalopathy. And in fact, their behavior, their cognitive functioning can be quite impaired with very little way to diagnose what's happening until post-mortem. There have been quite a few cases over the years. There was a very famous pro linebacker out of San Diego when the Chargers used to play there. He ended up killing himself and leaving a note specifically asking that the group in Boston review his brain to see if he had CTE, and unfortunately he did. And again, the only way to get a sure diagnosis of CTE is postmortem, which of course does not really help that patient during their life and their family as they're trying to deal with it. Other factors that will delay the recovery and result in poor outcome are acute abnormal imaging, right? If there's something on the image early on, expectation of poor outcome. One of the things I like to do when I try to assess a patient for one of our programs is I want to plant the seed immediately that that patient is going to get better, right? We don't want to have them thinking or expecting a poor outcome. So I usually tell them, hey, the good news is if you come to our program, we've had tremendous success in putting people back to work or returning them to their lives. And I know that we're going to be able to do that with you as well. So we got to set that expectation that they're going to get better, not set the expectation that they are going to be a patient for life and have these symptoms and not get back to what they were doing beforehand. And the last is extracranial injuries, things like skull fractures or facial fractures, or damage that would have resulted in the loss of teeth or broken teeth. Number 5, brain injury as a chronic condition. So now I'm going to turn from mild TBI to the more moderate to severe range of brain injury. So here we're talking about people that have had that level of brain injury, and they can evolve into a lifelong health condition termed chronic brain injury. So the World Health Organization, who many people in the United States had never heard of before COVID, now they're pretty famous. They've had a long history of having a definition for chronic disease. And you can see that on the slide that they have to have one or more of the following characteristics. And as I'm going through them, you can think of them as how they might apply to traumatic brain injury. The first is permanent, caused by non-reversible pathological alterations. Well, certainly brain injuries have that. You know, the brain cells, the neurons do not necessarily replenish the way the other cells in our body. So if we cut our finger in a couple of weeks, we don't even know where that cut was, if it was a mild cut. In brain injury, if the area is large enough and the patient may not have enough neurons that recover, and that could result in permanent non-reversible pathological alterations. These patients need special therapists, special trained therapists to help them in specialized rehabilitation programs. So even though you might have one of the world experts as a physical therapist in orthopedic care, if that therapist does not know neurological care, brain injury, they're really not going to be able to provide that patient with the best kind of care to get the ultimate outcome. So they are likely to need very specialized treatment. They may require long periods of observation, supervision, or care. I know that you have had many patients that need attendant care for early on, maybe forever, involving the care that they need, involving supervision and structure. And we know that it increases long-term mortality and reduces life expectancy. So brain injury as a chronic condition is often associated with increases in incidence of seizures, sleep disorders, neurodegenerative diseases. We've heard of connections between traumatic brain injury. I'm not sure why my screen is suddenly having its own seizure. Let's see if I can get back where we are here. What happened? Sorry about this. Okay, so we're back here. So maybe I shouldn't mention seizures again. But we were talking about neurodegenerative diseases like ALS has now been tied to brain injuries. There could be neuroendocrine dysregulations, problems with the thyroid. Maybe we've got patients that are now previously were borderline diabetic. Now they have diabetes that needs to be managed. And of course, poor management of diabetes can lend itself to a variety of other medical issues. And psychiatric illness is another problem that's associated with chronic conditions of brain injury. Non-neurological disorders include sexual dysfunction, bowel and bladder incontinence, and systemic metabolic dysregulation that can arise or persist for months to years post-injury. In 2013, Corrigan and Hammond described the need to have a disease management approach that may reduce the costs and improve outcomes. So we really need to try to prevent a variety of different things, which we'll get into in just a few moments. But one example would be diabetes, right? If a patient now has diabetes and we manage it sort of from a disease management standpoint, we can avoid a variety of the secondary issues of diabetes, like neuropathy or wound care issues or visual difficulties. Number 6, people with brain injury age differently and have decreased life expectancy. The Traumatic Brain Injury Model Systems in 2014 published a report that said about 1/5, 20% of patients died by the 5-year post-injury follow-up mark. So that's a pretty large percentage of TBI patients. Again, we're talking about moderate to severe brain injuries. We're not talking about mild brain injuries here. There's about half increase in mortality rate by age 80. About 2 times are more likely to die than those without a brain injury. And they're 1.5 times greater chance of survival after 1 year post-injury. So if they can get to 1 year, they're in a much better situation of surviving. Their 5-year study went on to say that among survivors, older age persons had overall poor medical, functional, and participation outcomes. Not too surprising, right? As we age, we develop more medical issues on top of the brain injury that might have been there. Younger age adults had poor mental and emotional outcomes, right? And here the thought is that they may not yet have had enough time to develop the kind of coping skills they need to deal with these brain injuries. Somewhat related to that is what we're hearing about our younger population who have had to deal with COVID from the standpoint of their socialization being affected, not going to school, being home alone, or in very small bubbles of people, and how much there's been in the area of emotional disturbances for these people. Overall, they found 8% have severe depression, 14% misuse alcohol, and 55% are unemployed. So when you're looking at providers and looking at how they're doing with traumatic brain injury patients, one of the questions that you need to be looking at is how many do they get back to work? What's the percentage of patients that they're getting back to work? The most often causes of death in post-injury of these patients that affect their life expectancy can significantly be affected by what we do as the medical profession. So patients that have heart disease or maybe cancer who are having regular screenings, well, their disease process is obviously going to be picked up much earlier, and they have a chance to get the kind of care to actually survive that, right? So having the right kind of care for those patients can reduce the likelihood of death because of that. There's a greater risk for death of seizures. So if the patient's being seen by an epileptologist who's really managing that and the patient is not having breakthrough seizures or status epilepticus, they can survive a lot longer. Accidental poisoning. Patients with brain injuries often make poor decisions. So they may put themselves at risk that they've accidentally overdosed on opiates and or alcohol. Sepsis, aspiration pneumonia, respiratory infections. I'll sort of group those 3 together to talk about the fact that if a patient's getting high quality care, these are often diagnosed early and can be treated very effectively. So patients that are, for example, in one of our supported living programs, Their vitals are being looked at daily. They're not necessarily needing 24-hour nursing care, but usually there's a nurse on staff. If there's something that's sort of gone awry with a patient or there's some question, they can be immediately assessed. Determination can be made as to whether that patient needs to see a physician or go to the ER. And these kinds of processes, sepsis, aspiration pneumonia, respiratory infections, can be effectively dealt with. Mental behavioral conditions, right? Patients that are depressed, overly anxious may do things that put themselves at risk as well. Number 7, rehabilitation is a continuum of care for people with brain injuries. So let's talk about that. On the left side, you can see we're going to talk a little bit about acute care. We're talking about a patient that's injured somewhere out in the community, let's say, and there's an emergency evaluation done in the field. Based on that evaluation, it's determined they need to get to the ER, the emergency department, and they may be air evac'd or taken by ambulance to the emergency room. There, all life-saving measures can be done, and the patient can be sent to an operating room for surgical care or neurosurgical care. If they, of course, survive that, they may end up in an intensive care unit where they are stabilized. And ultimately, if they progress, they can then be sent to the hospital's specialty neurotrauma or multi-trauma floors. And then from there, it really depends upon how they're progressing as to whether they would be sent to a long-term acute care or whether they are sent to a comprehensive, integrated inpatient brain injury floor or hospital for treatment. And now you're in sort of the post-acute phase of the continuum. And from there, patients may end up going home with family for outpatient treatment or home and community-based services, or they may go to the post-acute residential transitional rehabilitation program because they need structure and supervision and still help to maintain their medical status. From the post-acute program, they might end up not progressing at the level that one would need and might send them to a subacute rehab, or you can see they might go home with family or might go to some kind of supported living program. And we're going to talk a little bit more about each of these treatment arenas. So when we're looking at post-hospital rehabilitation programs that are residential, there are basically 2 kinds of programs. There is neurobehavioral and neurorehabilitation. Neurobehavioral are the kinds of programs where you have patients that are severely confused and dangerous. Dangerous meaning that they are so not connected to how they are functioning from a physical limitation standpoint and or emotional response standpoint that they may strike out at individuals, not because they're really trying to hurt them, they just have no way to control that behavior. And so they may hurt their family member or a caregiver or themselves because they are putting themselves in a position where they are physically unable to maintain the movement that they've done. So they might fall out of their chair, might hit something in the environment. The goal is to reduce or eliminate the severe behavioral dysfunction, and the primary ways of treating this is through applied behavior analysis, ABA, applied behavior analysis, and pharmacology. The kind of program they would go to is an interdisciplinary focus on applied behavior analysis and has neuropsychiatric treatment. We have several of these programs in the United States. One is in Colorado, another is in North Carolina. We have one in Georgia. So there are these specialized programs that patients may go to for a time being to get them to the stage where they can then progress to perhaps a neurorehabilitation program, which is also a program that is very active and aggressive in the treatment. Here the patients have severe, pervasive cognitive and some behavioral issues that may preclude them from outpatient treatment or going home and being managed by the patients, families. They may have comorbidities like substance abuse or psychiatric issues, and they may have impaired self-awareness. So let me talk for a moment about self-awareness. There are 2 conditions that are not mutually exclusive. One is where the brain itself has been damaged where it is incapable at that time to determine what they can and cannot do, right? This condition is called anosognosia. The patient's brain is unable to really look at itself, the body's functioning, and say, yes, I can do this or I can't do this. I had a patient once who was a cement truck driver and thought he could go back to work. I wasn't sure how he was even going to get into the truck's cab, let alone deal with, two different pedals and all the stuff he would need to do with his two upper extremities. But he was completely unaware. And it wasn't because he was trying to deceive anyone. It's just that his brain was not capable of really understanding the limitations that he was experiencing that time. The second kind of unawareness is the psychological defense mechanism of denial. We all have this. We all use this at times. If we experience something that is so anxiety provoking that we can't really deal with it head on, our psychological defense mechanism emerges and helps us to deny that something is going on. Now, that can be effective. It's very effective for short-term needs, not effective in the long term. And I mentioned that both of these things can happen at the same time. Anosognosia, in other words, physiological unawareness, and defense mechanisms. I'll give you a good example of this. I had a patient once who had a severe brain injury. No question, had a brain injury, needed surgical and neurosurgical intervention, had a long period of inpatient rehab, post-acute rehab, and initially was unaware of his deficits because of the physiological changes. And then as he improved, he developed a pretty significant emotional response. So there was psychological overlay to the physical changes in the brain that were hampering his ability to be aware. And then he got into litigation. And lo and behold, now the litigation was having this patient behave in manners that one would describe as malingering, right? And so you can end up in a situation where all these things are happening in different proportions at different points in the recovery curve, and they are not mutually exclusive. So although people want to say, oh, this patient has a TBI, a mild TBI, this one is malingering, it's not that simple. It's not just black and white. In neurorehabilitation residential programs, you're really working at trying to get the patient to a level of independent living and community reintegration. You're able to use group therapy, use the holistic milieu approach of the environment to help them. You can have individual therapy, cognitive rehab. They may use applied behavior analysis as well, and medication may be needed. And you need a transdisciplinary treatment team that can work together on these patients, with these patients. When we look at post-acute hospital care in the community, there are three kinds. Traditional outpatient, here it's very specific, remediation to improve a function. You may have PT see the patient and or OT or a speech pathologist, but it's really multidisciplinary and they're working specifically on very specific kinds of areas that need to improve function. You've got home and community programs to really look at with patients that have a strong potential for independent living and work reentry. They have reasonable awareness. They've got a lot of family and social support. And let's talk a moment about family and social support. We've all had patients where families are incredibly helpful to the ultimate outcome of these patients. Then there are families that patients are so, and their families are so overwhelmed that they can't seem to get out of the way of the care of the patient, right? They're doing everything for the patient as opposed to helping the patient get better. An example I'd like to give to patients about this is that, for most people, they've had children or, they've had familiarity with young children who have to learn how to tie their shoes. And when they start off learning how to tie the shoes, it takes a long time to do that, right? And you're in a rush to get out of the house with your, 3-year-old or 4-year-old, and you're doing it for them, right? But ultimately, you take the time and you teach them when you have more time, and they learn to tie their shoes. If we didn't do that, when they went off to college, we would have to go to college with them and tie their shoes for them before they went off to their lecture. Now, I know, of course, there are new slip-on shoes and Velcro shoes, but I think you get my point that the idea of rehabilitation is for the patient to do on their own and for families to help support that patient to do it, not for the patient's family to do for them. So that's where it's sort of a double-edged sword with family support, some that really know how to help and some that get in the way of the help because they want to do for them. I should mention one other is the day treatment program in the community, where we're talking about patients that have pretty severe and pervasive cognitive behavioral issues that they really need to be out of the house and supervised for maybe 6 hours at a time at a rehab outpatient center where they are constantly supervised, even through lunch periods. They are able to get group therapy, individual therapy. And again, you're looking at a situation where they're trying to increase that patient's independent living and community reintegration. The last area post-acute that is often looked at with patients is supported living, right? We've got sort of 3 programs associated with that. One are patients that are residual, slow to recover patients. Maybe these are patients of disorders of consciousness. Really, you're trying to maintain their health status and improve the responsiveness. Pharmacological treatment, some therapy to maintain that patient's health status and stimulation as part of the treatment. There is residential long-term care. Here, patients may be in a facility. We have several of those across the country. Again, these patients have chronic, stable issues that are really unable to live independently. They need the support, the structure, the supervision, ways to pick up on any kind of changes in their health status and help them avoid any kind of issues. Then there's the long-term community supports which occur in the community. You might be a patient that is able to live in an apartment kind of setting where they still are getting assistance. They are, again, chronic, stable pretty much, but still need some help in maintaining their health status and have support in the community. They may be able to walk to their work site or go to their work site. Maybe it's a voluntary site and then come back to their residential and care and this long-term site and get help there. The route of rehabilitation is unique. We like to say when you see one brain injury, you've seen one brain injury. But we know that there's a lot of good data out there to support the efficacy of post-acute and transitional rehab that enhances the patient's skills and helps them to become more independent, which reduces lifelong costs. So the better we can get the patients, the less money it's going to cost the health plans, the comp carriers, their families, society in general. They may not have to go on Medicare or Medicaid. So anything we can do to help them to avoid all that is obviously key to them getting better. And by focusing on the right program at the right time, which is such an important role that you're all involved in, we see these kinds of outcomes. Number 8, skilled nursing facility versus active rehab. So how do we know which is the better direction to go? So typically, younger persons at a dependent level of care will likely need to go to a rehab program. They may never have participated in active rehab, but now are able to participate with at least 3 hours a day of treatment. And the goals are to reduce long-term disability, which reduces overall cost of care. It's estimated about 250,000 people are in nursing homes with brain injury who would be better served in other environments. But once they get in there, it's hard for them to move out of there. For those over the age of 65, they're more likely to be discharged to a SNF, I think partially because we're just more accepting of the fact that if they're over 65, they can be in a skilled nursing facility. They typically have longer hospital length of stays. And despite all of this, we still see a fair amount of evidence that these patients who go to intensive rehabilitation improve in cognitive and physical functioning. And if we can get a patient to an acute rehab program in their communities, they're more likely to be discharged to their communities. Number 9, a high portion of patients with spinal cord injury also have traumatic brain injury. The model system for spinal cord injury indicates about 28% also have had a minor TBI, right? Well, that sort of comes to reason, right? If someone has done something that severed their spine or crushed their spine, they're likely to have done something to their brain, whether it's acceleration, deceleration, or they've hit their head, that they might have also suffered a brain injury. You would have to do a motor-free neurocognitive screening to really look at this, right? Because a lot of the neuropsychological tests involve manipulation using the hands or a variety of other techniques that involve motor functioning. So you would need to do some kind of test that doesn't have that motor functioning. Early detection can really have a huge impact on that patient's spinal cord rehabilitation, right? Because they can then adjust the program for those patients' cognitive difficulties, their memory difficulties. They may need to use memory aids, problem-solving strategies, so on and so forth. We do know that patients with dual diagnosis of traumatic brain injury and spinal cord injury have a longer length of stay, and they are at a greater risk for rehospitalization. Number 10, managing the continuum of care is essential in moving patients through the most appropriate and cost-efficient level of care. So getting the patient to the right level of care at the right time is crucial. Centers of excellence typically give you the best value and expertise, though they are seen as being overly expensive. Again, it's one of those things, I think, that you get what you pay for. Case management is essential to a good outcome. I can't stress this enough. The best outcomes we get is when we work in a collaborative team effort with our payer case managers and adjusters. When they are part of our team and we are brainstorming together how to deal with certain things, we really get the best outcomes, right? These patients are complex. They go off the rails. If they were simple patients, if they had a simple kind of injury, we wouldn't be seeing them and you likely wouldn't be managing them. So you are getting the toughest cases and we're seeing the toughest cases. And so again, getting back to each case is unique. We need everyone on board to sort of brainstorm how to get this patient to the best kind of outcome. And we need to focus on long-term durable outcomes. It's not just good enough how to get that patient to be able to do something in the short term. How do we get them in the long-term situation of having durable outcomes? One of the things that we do is we assess patients 3 months post-discharge and 1 year post-discharge to see if our treatment effects at the time of discharge are still there or not. So dollars spent up front reduce dollars in long-term management and enhance quality of life. It's really a win-win kind of situation. So if we're able to manage the care up front, we can really increase the patient's quality of life, and then it really is a win-win situation. Here is my contact information. It's also part of the handout that you can reach out to me if you would like to do so. So that is the end of my formal presentation. And if some people have some questions, I'll be glad to take those on.
I see no questions at this time. You did a phenomenal job and presented a lot of information. So thank you very much for that, Doctor. We do appreciate your thorough information. And I love that you did the top 10 because that makes it really easy and compact. But boy, that's a lot of information to digest and so much to know. And I think it is interesting. You mentioned Liam Neeson's wife. We actually had an attorney here in the workers' compensation arena, and his mother lived with them. She slipped, fell, and hit her head on the bathtub, and said, "Don't worry about it, I'll be fine." She laid down, and that was the last time she spoke to them. And so I think we just have to be vigilant every time we have an injury, or even if we don't think it's a real injury, to have it checked out. Thank you for the sage advice and and all the information for our workers' comp community. All right, everybody, you should be receiving those certificates in 1 hour. If you don't get it, please remember to let me know within the first 30 days, but do check with your IT department first to make sure it's not a firewall issue or that it's in spam. Other than that, please make sure that you check the calendar for upcoming events. We have quite a few other webinars for the summer school series, and it's not too late to register for them. My favorite one coming up is going to be on, I believe it's the 25th of June. It's going to be applicant copy services that are going to talk about what they do, how they do it, why they do it, rules, regulations, and how it affects you guys. And then later in that afternoon, we're actually going to have a attorney that's going to be speaking on trying to wrangle in the applicant attorneys that request all these records for the applicant copy services, because they're two different groups and they should be handled two different ways. So I hope you join us for that. All right. Thank you again, Dr. Irwin. Oh, not Irwin, that's your first name. My apologies, Dr. Altman.
Yeah.
Thank you. Have a great day, everyone. Bye-bye now.
Thank you. Bye now.
Log it off. It's not logged off yet.